So I'd like to share with you all some data that we presented just earlier this month at the ASCO meeting. This is our abstract early signs of efficacy in patients with anti-PD-1 naive and anti-PD-1 resistant head and neck squamous cell cancer treated with NBTXR3 and SBRT in combination with nivolumab or pembrolizumab in the phase 1 trial study 1100. Next slide, please. Here are my disclosures. Next slide. So just as a reminder, outcomes remain limited for patients treated with anti-PD-1 in the first, second, or further lines of treatment. Progression-free survival is short. Many patients do not respond. While there may be a small tail of patients with durable response, the majority of patients are primary or secondary non-responders to anti-PD-1 treatment. And this is highlighted again in the Keynote 048, Keynote 040, and Checkmate 141 studies. Next slide, please. There has been some thought that perhaps using SBRT or radiation could enhance response to immune checkpoint blockade. And this trial by Memorial Sloan Kettering Cancer Center was exploring nivolumab randomized against nivolumab plus SBRT for patients with recurrent metastatic head and neck squamous cell cancer. However, there did not seem to be any difference in overall survival with the addition of SBRT in this group, and these were anti-PD-1 naive patients. So prompted by, in particular, some of the very promising preclinical data that Dr. Paris shared, the thought of the 1100 study is that perhaps by providing local control and priming an immune response with NBTXR3 plus radiation, one of the goals is to explore whether this combination with immune checkpoint inhibitor can improve and deepen response to immune therapy for patients naive to anti-PD-1 therapy. And a second goal, can this combination reverse resistance to anti-PD-1 therapy for refractory patients? Next slide, please. So just to briefly go over the study design for the 1100 study, the patients receive a one-time intratumoral injection of NBTXR3. This is followed by SBRT over 3 to 5 fractions, depending on the site of radiation. And then the day after SBRT completion, patients begin anti-PD-1 therapy with pembrolizumab or nivolumab. The dose escalation portion of the study is complete. In this portion of the study, there were 3 cohorts. The first, local region recurrent or recurrent metastatic head and neck squamous cell cancer. And then the second and third cohorts were patients with lung or liver metastases from any primary tumor eligible for anti-PD-1 therapy. Now we're on the dose expansion phase of the study here on the right. The cohorts have been adjusted such that there are 2 cohorts of patients with recurrent and metastatic head and neck squamous cell cancer, one group anti-PD-1 resistant, the second group anti-PD-1 naive. And then the third cohort is patients with lung or liver metastases from primary tumors eligible for anti-PD-1 therapy, and these patients are anti-PD-1 resistant. The primary objective is to further assess the safety profile. Secondary objectives, evaluating safety, feasibility, and anti-tumor response of this combination of radiation-activated NBTXR3 in combination with anti-PD-1, and then exploratory objectives of survival, duration response, biomarkers of response, and response in non-injected, non-irradiated lesions. Next slide, please. Here are some of the baseline characteristics of patients, specifically in the recurrent metastatic head and neck squamous cell cancer cohorts for study 1100. I'll just highlight a few of the key areas. And we see here that, previous slide, please. Patients are separated into immune checkpoint inhibitor naive or resistant. And we can see that the majority of patients have had multiple prior lines of therapy, especially the immune checkpoint inhibitor resistant group. The majority of those patients had at least 3 prior lines of therapy. You can also see that majority of patients have multiple lesions being treated. In the naive group, about 65% of patients had at least 2 lesions. And then in the resistant group, about 79% of patients had at least 2 lesions. And I will note that in this trial, patients were limited to have no more than 5 progressing lesions. And then at the bottom, the CPS score, and I apologize, the bottom line is cut off, but in the naive group, 75% of patients had CPS 1 to 20, 25% had greater than 20. And in the resistant group, 15% of patients had CPS less than 1, 42% had 1 to 20, and another about 40% had greater than 20. Next slide, please. In terms of safety, there were very few treatment emergent adverse events related to NBTXR3. In general, less than 10% of grade 3 or greater serious treatment emergent adverse events were related to NBTXR3 injection procedure, radiation therapy, or anti-PD-1. About 10% of the grade 3 or greater treatment emergent adverse events were related to radiotherapy, which is in line with reported data. There were no unexpected side effects that emerged related to the radiotherapy and NBTXR3 combination or anti-PD-1 exposure or injection procedure. Next slide, please. So now I'd like to move to efficacy in patients naive to anti-PD-1 therapy, and I'll separate between naive patients, and then later I'll go to efficacy in patients resistant to anti-PD-1 therapy. And please note again that this is an ongoing study, so these data are preliminary based on a data cutoff of April of this year. Next slide, please. So just as a quick reminder of these patients in the anti-PD-1 naive group, this is a similar population to those in the KEYNOTE-040 or CheckMate 141 study. These patients did have a fairly heavy tumor burden. 65% of patients had at least 2 lesions. In this group, there were 33 patients evaluable for safety and 25 evaluable for efficacy at the cutoff date. And again, the CPS score below 20 in 75% of patients. 10 of the 33 patients had oropharynx HPV positive disease. Next slide, please. So here's the waterfall plot of best change in all target lesions diameter sum. So this is not just the injected irradiated lesion, but all target lesions. And we could see that there was an objective response rate of 48% with a median duration of 54 days and a disease control rate of 76% with a median duration of 65 days. We're here potentially seeing systemic control in anti-PD-1 naive patients with a high disease burden. 24% of patients have 4 or more lesions and 66% have 2 or more lesions. And as a reminder, only 1 lesion here has been injected and irradiated. Next slide, please. In terms of progression-free survival and overall survival, again, this is for the immune checkpoint inhibitor naive group. The median progression-free survival from NBTXR3 injection was 7.3 months, and the overall survival from NBTXR3 injection was 26.2 months. Next slide, please. It is very difficult to make any direct comparisons between studies with different patient populations, but just as a rough illustration, comparing the results seen in the 1100 study thus far to the KEYNOTE-040 and CheckMate 141 studies, both similarly with an immune checkpoint inhibitor naive population. We have an objective response rate of 48% in the 1100 study. Compared to KEYNOTE-040 and CheckMate 141, objective response rates of about 13 to 15%. And the progression-free survival for the 1100 study is very promising when compared to the other KEYNOTE and CheckMate studies. Next slide, please. Now moving on to efficacy in patients resistant to anti-PD-1 therapy. Next slide. So this population is those that have developed primary or secondary resistance to prior anti-PD-1 therapy. And so just as a reminder, using the progression-free survival graph from the KEYNOTE-048 study, this would be patients who are kind of in this, early, refractory setting where patients develop primary and secondary resistance kind of in that 6 to 12 month timeframe from starting checkpoint inhibitor therapy. These patients are not those who have responded or have had durable response to immune checkpoint inhibitor therapy. Next Next slide, please, or next graph. So just as an illustration, the patients who have entered the 1100 study who have been refractory to anti-PD-1 therapy, typically looking at the time from the starting date of prior immune checkpoint inhibitor therapy, develop progression within that initial about 6-month window, 6 to 12 months, similar to those patients who developed resistance to pembrolizumab alone in the KEYNOTE-048 study. Next slide, please. So just as a reminder of some of the key baseline characteristics of this group, there were 35 patients that were evaluable for safety, 25 evaluable for efficacy. The majority, all of the patients have developed progression, but 83% of these have been verified based on the data entered thus far. And these patients do have a heavy tumor burden. About 60% of patients have 4 or more lesions in this group. So a very heavy tumor burden, about 79% have 2 or more lesions. And then this is a heavily pretreated patient population. Nearly 40% of these patients have had 3 or 4 lines of prior therapy. And majority of patients have had multiple prior lines of treatment. In terms of CPS score, 15% of patients in this group have a CPS score less than 1% and 58% below 20%. There were 12 patients in this group with oropharynx HPV positive cancer. And so this group of patients who have developed resistance to anti-PD-1 therapy are a similar population as the KEYNOTE-040 or Checkmate 141 patients treated beyond progression or failure. Next slide, please. Here's the waterfall plot for the best change in all target lesions from baseline for this immune checkpoint inhibitor resistant group. We can see an objective response rate of 28% with a median duration of 128 days and a disease control rate of 68% with a median duration of 58 days. And just as a reminder, again, these patients have had a high tumor burden. 60% have 4 or more lesions, but only one of the lesions has been injected and irradiated. And so we are potentially seeing some systemic control in these patients who have progressed on prior anti-PD-1 therapy and have high disease burden. Most of these patients do not just have the one lesion that was injected or irradiated. Next slide, please. So looking at survival data, the progression-free survival from NBTXR3 injection was a median of 4.2 months. And the overall survival from NBTXR3 injection for this group is a median of 7.8 months. Next slide, please. So as I mentioned, this group of patients who have developed progression or resistance to anti-PD-1 therapy are similar to those perhaps in the Checkmate 141 trial for patients who were treated beyond anti-PD-1 progression. And so there has been an additional analysis of patients from this Checkmate 141 trial, those treated beyond anti-PD-1 progression. This is the waterfall plot for those patients. And then the median overall survival from the time of immune checkpoint inhibitor initiation was 12.7 months for this group. Next slide, please. And so for our patients on the 1100 study, there has been a calculation of an overall survival 2, which is the time from first immune checkpoint inhibitor therapy. The prior overall survival data were from the time of NBTXR3 injection. And so here's an additional calculation from time of first immune checkpoint inhibitor therapy as a way to try to have some comparison with patients treated on some of the other studies where survival is reported from the time of immune checkpoint inhibitor initiation. And so again, this is just for the patients who are resistant to immune checkpoint inhibitor therapy. And this is a second calculation for the overall survival. And so the overall survival 2 for these patients from the first immune checkpoint inhibitor therapy start date prior to starting on the 1100 study was 31.8 months. Next slide, please. Just as a very rough comparison, with of course the understanding that these patients are different populations, but just as a very rough illustration, on the left, we have patients from the Checkmate 141 study who were treated beyond anti-PD-1 progression. So the waterfall plot on the left there versus the 1100 patients, immune checkpoint inhibitor resistant patients who are treated beyond progression with the waterfall plot on the right. The survival for the patients on the Checkmate 141 study from anti-PD-1 initiation was 12.7 months, and the overall survival 2 number that I just mentioned for the 1100 study patients from the time of immune checkpoint inhibitor therapy initiation was 31.8 months. Again, this is a very rough comparison. The patients on the 1100 study may have had other treatment lines after the initial anti-PD-1 progression, but really just as a rough illustration. Next slide, please. So just to summarize, I think the data from the 1100 study are promising, very promising, and they warrant further exploration and randomized trials for both immune checkpoint inhibitor naive and resistant patients with local, regionally recurrent, or metastatic head and neck squamous cell cancer. In general, this treatment was feasible and safe with no unexpected findings. Less than 10% of grade 3 or greater serious treatment emergent adverse events were related to radiotherapy, injection procedure, anti-PD-1, or NBTXR3. There was a high response rate with metastatic patients, both naive and refractory to anti-PD-1 therapy, which suggests some systemic component of control. In the naive patients, the objective response rate was 48%, the disease control rate 76%, median progression-free survival 7.3 months, median overall survival of 26.2 months. In the immune checkpoint inhibitor resistant patients, a response rate of 28%, disease control 68%, median progression-free survival 4.2 months, and median overall survival 7.8 months. And so these are very promising data that certainly warrant further